Today we will do examination on an infant, which is a bit challenging in pediatric age group. The moment you start examining an infant, generally they start crying. So you have to keep in mind that opportunistic examination is a key to success. You have to observe as many things as possible without touching the patient. And if, for example, patient is already in mother's lap and he is comfortable, don't lose this opportunity and gather few information. Look at this young infant who is 5 months old. He is lying comfortably in bed with normal semi-flexed posture of both lower limb and upper limb. He is moving his limbs and he seems to be attentive and looking all around. His complexion is normal. He is pink in room air and there is no obvious tachypnea or dyspnea. So we can precisely presume that probably there is no respiratory problem or cardiac issue in this case. You can see that his eyes are shiny and he seems well hydrated, appropriately built for his age. So we will do height and weight, rather length and weight in this young infant at the end of the examination to see whether the growth parameters are normal for his age group. And one more thing which you need to consider is any evidence of dysmorphism. So before I touch my patient, I would like to check for breathing rate. It's 40 times per minute, which is normal for this pediatric age group. For temperature, there is one rough method that I check with my hand, or secondly, we can check it with the help of thermometer. Next thing would be palpation of the pulse. Check for the brachial pulse. So this pulse is regular, normal in volume, and it's around 110 times per minute. With the examination of hand, and there is an IV line being placed on the dorsum of right hand. There is no polydactyly, syndactyly or acrodactyly. He has normal hands and there is no evidence of any palmar erythema or clubbing. Similarly, there is no widening of the wrist, and we look at the skin, which is normal. There is no pigmentation or any evidence of any angiomatous lesions. Here I would like to look for BCG scar, which is normally placed on the lateral aspect of right deltoid. Next, we need to look at the head. Head examination will give us information about few diseases. First of all, we will be looking at the shape of the head. Shape seems to be normal and there is no asymmetry or bulge. Similarly, looking at the size of head, I will put measuring tape at the occipital protuberance on the back side, and anteriorly it will be level of superciliary arch. So this baby has OFC circumference of 44 centimeter, which is normal for this age group. Shape of the head may be abnormal in few conditions. This can be small head, especially in craniosynostosis, when there is a premature closure of the sutures, or head may be large in certain other conditions. Odd shapes or different shapes of the head may be as a result of premature closure of some sutures, for example scaphocephaly, where sagittal suture close prematurely and this is oblong from front to back, while if the coronal suture closes prematurely, that would be compressed head, which is called brachycephaly. When lambdoid and coronal sutures close prematurely, then shape will be asymmetrical and this is called plagiocephaly. In case of premature closure of the metopic suture, this would be trigonocephaly or turicephaly, which is like high head. After examination of the shape and size of the head, we have to look for fontanelle. Fontanelle give us information about few diseases. There are actually two fontanelle in the infants. One is anterior, which size is generally around 2.5 into 2 centimeter. It is rhomboid in shape, and in around 3% of the population, when the baby is born, the posterior fontanelle is open, which is around 1 into 1 centimeter, but then it closes early on in 1 to 2 months time, while anterior fontanelle generally closes in 18 months time, but it may close early, sometime late. When there is a large anterior fontanelle and it is not closing appropriately with age, then the possibilities may be rickets, there can be hydrocephalus, achondroplasia and certain other conditions. The next step would be to look for sutures, whether there are any diastasis of the sutures or are they closing normally. This baby anterior fontanelle is around 2 into 1 centimeter wide. It is normal, it is not sunken, neither it's bulging. If we go back to posterior, there is no opening of the posterior fontanelle which is already closed. Similarly, now I will sweep my fingers laterally to look for any diastasis of the sutures, which is none. These sutures are closed, but there is no overriding of the sutures, as you can see. The next step would be to look for any bulge, or in cases where you find a large head, sometime though rarely, there is a vein of Galen malformation. Here you can find a bruit on the parietal region. Next would be to look for eyebrows, that is the normally placed and they are not very bushy, because very hairy or bushy eyebrows can be in few conditions like Cornelia de Lange syndrome. This baby does not have much hair and they have already shaved, but you have to look for any low hairline as well, for example in hypothyroidism and certain other conditions. Look at the eyelashes. If they are very long, again indicate Cornelia de Lange syndrome, where along with the bushy eyebrows there is a cynophorus, meaning by that there are hair in between as well and no intervening clear area like the normal people have. Now look at the ears. We should need to look for pinna, whether it's normally formed and recoiled. There is no malformation of the ear and auditory meatus is patent. Normally when we join both medial and lateral canthus and then draw horizontal line, 1/3 of the ear shall be above that horizontal line. In this case this is normal, but if they are low lying, then syndromic condition like Down syndrome need to be considered. Now have a look at the eyes. He is moving his eyes all around. Look at the eyelids. There is no superficial lesion and there is no obvious ptosis. In case of ptosis, this can be either congenital or in cases of third nerve palsy or Horner syndrome or myasthenia gravis or certain other condition like external ophthalmoplegia and rarely in some muscular dystrophy. Just gently retract the upper lid and look for any jaundice. Though daylight is best for looking at the jaundice, retract the lower lid and look for any pallor. You can see in the oral cavity, under surface of the tongue, but the best possible site is conjunctivitis. Now I'll be looking for sclera at upper and lateral part of the eye globe, and you have to gently retract the lid. It is normally whitish in color. If that sclera is yellow, it is often in case of osteogenesis imperfecta. And normal sclera is shiny, it's not dry like in this baby, and bitote spot or telangiectasia etc. can be indicative of few conditions. Like in older children, ataxia telangiectasia, you may find telangiectatic lesion, bitote spot are indicative of vitamin A deficiency. Then we will be looking at cornea. Cornea is normally shining and clear. There is no xerosis cornea and there is no obvious ulceration or any other. Looking at the cornea, keep in mind there can be megalocornea or there can be microcornea in certain conditions. We say megalocornea when the diameter of cornea is more than 13 millimeter, and this may be an indication of glaucoma. When this diameter is less than 10 mm, then we say that this is microcornea. Now look at the bridge of the nose. There is a distance between the two inner canthi, and this distance is roughly equal to a diameter of an eyeball. When this distance is wider, then this is called hypertelorism. If distance is narrow, then this is called hypotelorism. Again indicative of certain syndromes and conditions. Next, look at the shape of nose, which is normal. He is breathing comfortably through his both nares and there is no obvious discharge from the nasal side, neither any noisy breathing. Similarly, look at the cheeks. They both are flat. There is no obvious flattening or asymmetry of the face. Now looking at the oral cavity for hydration status, for any evidence of the mucosal rash or mucosal bleed, oral thrush. Next would be neck. Shape of the neck and any obvious asymmetry will give us clue for many things. His neck seems to be normal in shape. There is no obvious any asymmetric pathology or bulge on any side. The possibility could be of cystic hygroma, sternocleidomastoid tumor. Similarly, we have to look for any goiter. If the baby is having bigger goiter, they are generally dyspneic. Though it is wiser to ask your patient to swallow, but in young infants you cannot do that. So you will be doing only inspection and look there. Is there any swelling? Next, look at the shape of the chest, which is normal. Horizontal diameter is more than the AP diameter. In obstructive lung pathologies or in condition, for example, meconium aspiration syndrome in neonates, where they are breathing hard, sometimes the AP diameter does increase. So this chest shape is normal, it is symmetrical, and his both nipples are normally formed, areolas are symmetrical. They are normally placed. Board-like chest with widely spaced nipples could be one clue, especially in baby girls for Turner syndrome. With the shape of abdomen, which is a little bulging with central umbilicus which is inverted. There is no obvious visible pulsation, scar marks or any other pathology. And now we'll be very gently looking for pedal edema about 2 centimeters above the medial malleolus, putting your right thumb gently and keep looking at the patient face that he does not get hurt and see is there any dip. Finally, look for external genitalia to make sure it's normal. So these are normal genitalia with almost normal phallic length, and rugosities of the scrotum are normal. To make sure that testes are normally placed and they are not undescended, to start milking for the testes from lateral side gently and palpate in the scrotal sac. Finally, we will check for weight and length of the baby. Probably in every case it may not be important to check blood pressure in very young infant because mostly they will start crying and your findings will be not valid. We can check blood pressure with an appropriate size cuff. We can check for developmental dysplasia of hip. Both Barlow's and Ortolani maneuvers can be done, especially in cases where we have some doubt. Thank you very much. If you have any comments, queries or suggestions, you can drop in the drop box.